Tim, nice to see you again.
Yeah, good to see you, Ollie. Yeah, how's your week been?
Yeah, it's been busy, bit busy juggling, peak health coaching, pushing forward, busy as a PCN clinical director, but the challenge is good, isn't it? I like it.
Yeah, and I can see you've been on LinkedIn. You've been busy on LinkedIn as usual. I think you commented actually on a study from Manchester University on the impact of social prescribers. I just wondered maybe that might be a good place to start off, have a bit of a conversation about that. So what did you notice about that?
Yeah, brilliant. There's two things I wanted to talk about actually. There's that, and then there's the new report from the King's Fund. I think they're sort of almost related, really. Yeah, it was really interesting. I saw Caroline, the chief exec, had posted on LinkedIn. Great to see that. I think LinkedIn's a really useful way of sharing, kind of the ideas that are emerging, isn't it? So a really big study. It's reputedly the biggest study into social prescribing. Involves 4 million patients from the GP survey. And what they'd done is they'd looked at the kind of some of the experiences of general practice and some of the outcomes in general practice as reported by these 4 million patients. And they'd seen correlation between good outcomes and PCNs and practices that had more social prescribing link workers.
Yeah.
Which, interesting. I wasn't sure whether it was really, whether that was just an association or whether we could be really sure that there was causality. Um, but it did make me think, nevertheless, whether it's the social prescribing link workers directly that's causing that change in outcome, or whether it's just the fact that PCNs and practices that choose social prescribers as opposed to other roles, and we can come back to that in a second. Where so they're proactively choosing social prescribers, whether that indicates a sort of way of working or an approach that leads to better outcomes for patients.
Yeah, it is really good, isn't it, that this is being looked at because I suppose in places where now, people can choose, I suppose, a bit more where they spend that money with those yeah,
Additional
the
roles.
additional roles. It's kind of and we're seeing a little bit of pulling back on that. It is good to see some evidence that these roles are making a contribution. I know it kind of felt to me it felt like quite modest, but I suppose at a population level, it did look like it was in certain areas anyway. It looked like there was definitely an association, and in a positive way from having social prescribers. But like you say, it was mainly on the numbers of social prescribers, which again, is that a good measure? Is that a good
Yeah,
measure?
and you raised a couple of good points there because I guess this is about population health, isn't it? And sometimes it can be hard to sort of make population judgments, isn't it? Who is commissioning on the basis of large scale population change? And I think I think this is really pertinent because I mean I know as a PCN CD myself, at a PCN level now, there's a lot of choice about how you spend your additional roles money.
Mm.
And for those who don't know, it's probably been the biggest investment in primary care in the last 5 years, has been paying for these new additional roles in primary care. And initially, they were quite strict about where you could spend it. And in fact, social prescribing link workers were one of the roles that PCNs had to invest in. Right at the start, it was pharmacy and link worker. And then over the last 5 years, the roles have expanded, and you can invest in pharmacists, physios, OTs, paramedics. And I have seen there's been a sort of little bit of a divide really, nationally and locally in our PCN. There's a split between GPs deciding to invest in roles that perhaps have a more direct business effect for them. So, something like a paramedic who can do home visits for you, or a pharmacist who can take some of the prescribing workload off you, can have a direct, clear benefit to your workload and your bottom line really as a GP practice. There are other roles like social prescribing link workers, or obviously health coaches, which we're very interested in, and care coordinators that perhaps don't have such an obvious connection to your bottom line as a GP practice. But yet we know from population data and from a whole host of kind of, emerging evidence base now, that really is the way to go, isn't it? If we want good population health. Um, and we can look at that when we think about the King's Fund drive at the moment. But I feel it's a difficult situation. I do feel some sympathy for general practice at the moment because they've been pretty hard beaten. Everyone sort of thinks sometimes, oh, selfish rich GPs are just on the golf course. There's that characterization, isn't it? But I know GPs are working, really, really hard. There's few and far between those GPs that are just taking it easy and having a good life. And they've had collective action. It's as close as GPs ever get to striking over the last year because they feel they've been pushed to the limit of being underinvested and a lot of general practice closing just because they're not financially viable. So to put them in the position of deciding, which roles they're going to invest in and whether they'll invest in roles that help their business and their bottom line, or whether they're going to be bold and ambitious and seek things that are going to be good for population health. It feels like a bit of a Hobson's choice. It's almost like putting them in an impossible situation, really. And nevertheless, there has still been so many PCNs around the country that have invested in social prescribing, invested in health coaches, and good on them for maintaining that kind of like commitment to patient care, I guess, really.
Yeah, well, we know that, what we want is to reduce demand, I suppose. How do you reduce demand? And for me, it would be about, well, you need to build people's confidence, knowledge, and skills. Well, who's going to do that? Who's going to be able to spend the time doing that? And it probably is going to be those people fulfilling those roles and those additional roles. So the social prescribing link workers and the health coaches and the care coordinators. I don't think most GPs that I'm aware of have lots of time to kind of invest in that part. Although, most GPs are, of course, they are really holistic. Um, yeah, I suppose it's maybe less about the kind of the business and the bottom line than GPs really feeling the pressure of the job. So you're bound to look for people to bring people in who can take some of that pressure off, like you've just mentioned there. And so I can absolutely understand why people would do that. Um,
Yeah.
and
And
it is difficult because,
it
as I
is,
said,
isn't it? And I think you also hit the nail on the head there that actually those sort of investments in reducing demand in the longer term, there's a very compelling argument for it, but it doesn't help you in the here and now. So, you're asking people to sort of like plan for 3 or 4 years down the line when they're not sure if their business is going to survive the next year. And we know that. I mean, that's the premise of what we do, isn't it? The premise of why we started Peak Health Coaching is that, I felt as a GP that the only sustainable future going back to the sort of Derek Wanless study, having a fully engaged population, we're really clear that a fully engaged population, people that feel empowered and are able to look after themselves better, they Wanless showed that they absolutely economically work better. But I think my strong clinical feeling was that, we want to be working with patients that are more enabled and more involved and more engaged. Particularly with long-term conditions. You want to be working with people, looking after their diabetes or chronic pain or mental health, where your support is helping them to, to be more capable, if you like, really. And for me, that's exactly what social prescribers, health coaches, and care coordinators enable. Social prescribers activating things in the community, bringing those sort of social determinants of health onto the table. Health coaches, directly coaching people in their own self-management skills and building their confidence and their knowledge base related to their situation. And then care coordinators for people that, where, they have super complicated, sort of medical, social, emotional situations and coordinating their care, and doing that in an enabling style that tries to sort of keep their choice at the forefront and keep them involved as much as possible. Those are the tools and the levers, if you like, for a more fully engaged population. And it's hard to think that we shouldn't be investing in those, but you can understand why GPs, GP partners in PCNs, given the choice, are not necessarily choosing them at the moment.
yeah. And I know that we've long kind of been on this path, Ollie, and we know we can see the value. We can absolutely recognize the value of these additional roles. But I think for most GPs, kind of jobby GPs, they were kind of meant to be additional roles, and it feels like they're having to make a choice between something that's going to help me right now and keep me safe in terms of working, or something that's going to be, better long term. Like you say, it's been difficult to kind of get people to make that decision, which we think is, the right thing is to invest longer term, but
Yeah.
it's very difficult. We need more money and more resources, I suppose, to
Mm.
allow people to make the what we think might be the right decision. Because it
Yeah.
feels like the right thing to do, doesn't it? The people are more confident, more knowledgeable and skillful to self-manage their long-term conditions. That's just not it's just the right thing to do. Whether it kind of saves you an A and me admission or whatever, that's it's just it feels like the right thing to do.
Well, we do know, isn't it? There is really strong evidence that if you, I mean, from the patient activation measure evidence, for instance, there's a huge number of peer-reviewed published studies now across the world, a lot from England, big study down in London, in Islington, that showed that if you do build people's skills, knowledge, and confidence to look after themselves, what's been termed their patient activation, that correlates and leads to causality in changes in their use of primary care, their use of secondary care, their satisfaction with care, and their end outcomes in terms of their quality of life. So we know if we can do it, it does help all of us. It's a win-win-win all round, isn't it? It's just that our system at the moment isn't really focused on that. It's not being allowed to focus on that really. I mean, yeah, I think I guess that's probably what I'm looking for in the 10-year plan. Really, is a clear, consistent strategy with contracts, with the funding in the right place to allow us to focus on that enabling aspect of care. Um,
Yeah.
we've been distressed, haven't we, seeing across the country some sites where they're drawing back on health coaches and social prescribers to now invest in GPs. The R's roles and now includes GPs. So not surprisingly, GPs being the prime decision makers are deciding to invest in GPs. It's happening in my network. But in my network, we are holding on to social prescribers and health coaches because we're negotiating and trying to see, that it's worth keeping that going as best we can. But we are seeing some places in the country, aren't they, where they're pulling back on those roles.
Yeah, really difficult. People we've trained, people we know are really good and making a really, really good positive contribution are losing their jobs. And that is really difficult because we feel like, and they feel like they are making a contribution. But people are turning around saying, well, we can't see the value of what you're doing, which is really hard, when you're working your socks off to kind of do something really good. And actually, people turning around saying, well, actually, don't think it's that valuable.
Yeah,
And it's difficult. And so any of these studies where they are trying to kind of draw in and understand what the value is, because it is important, but we
yeah,
do not want just lots of people in the system being really busy and lots of activity, but actually that not translating to kind of positive outcomes. And again, that's one of our things, isn't it, as a company, is positive impact. All right? We don't want to just do this job to pay the mortgage. It's about having a positive impact
yeah.
down the line. So yes, doing great training, but that having positive impact.
Yeah,
Uh,
and it's so hard to measurement's hard, isn't it? It's so hard to, um, you know, something like health coaching, social prescribing. It's very individualism, it's very personalized, and it on an individual one-to-one level, you can see the stories, you can see the trajectory of people's lives changing, can't you? But then, how do you translate that at scale into something that's going to be able to influence, distribution of funding across the whole system? So this study was great, I think, in that it's really trying to look at a population approach, large scale, 4 million people's feedback from the patient survey. But we've got to be careful, haven't we, that we are, attributing it to what's actually going on. So triangulating, I think, those large population studies with the sort of, stories we hear. And it was lovely, wasn't it? And we had Hannah Fredericks, a fantastic health coach team leader from Southampton, the Live Well partnership down there, where their PCNs and GPs have really supported building a robust health coaching team. And we saw videos of people like John, didn't we? And some of the other people that were filmed down there talking about the value of health coaching and the physical activity programs and the sort of the community sessions they've had together and how much impact that's had on them in their lives. So you want to see these measures that triangulate both large scale stuff with individual stories, I think.
yeah. And I think that maybe brings us on to the kind of the King's Fund, their kind of which is a lovely kind of a title, wasn't it? Bold thinking for better health. I just love
Yeah.
that. What it is to kind of be really bold in your thinking. What do we need in order to be bold? Because I think that's what we need. And they will then be drawing people and not just looking at the UK, but looking kind of worldwide, looking for kind of best practice and seeing what is working, very much keeping the kind of the patient at the center of everything that they're doing and communities as well. But really grappling with that difficult to measure, measuring kind of what matters to people,
Yeah.
and delivering care that really matters rather than the care that we think people should should have. So I think it's really interesting. I don't know. What do you think?
Yeah, no, it's lovely, isn't it? See Sarah Woolnough as the new leader there, sort of getting her sort of, really establishing where she wants to take the organisation. We've respected the King's Fund hugely, haven't we? We were delighted to have, Chris Ham talk at our conference, and he's been a previous chief exec of the King's Fund, and I think they've consistently been the voice of reason. I think, alongside organisations like the Health Foundation. So to see their new strategy really focusing on person-centered care. They've got sort of four things, haven't they? It's got to be people-focused, and it's lovely to see them saying that's patients and the workforce, the staff as well. They tend to know what really works, don't they? But then a real focus on health creation. The sort of the proactive, positive activities we've been talking about. And then drawing as well on the kind of importance of the social context and bringing digital innovation. Of course, we all have to do that. So those sort of four priorities really struck out to me, but they really resonated, I think, with the that Manchester research we've just talked about, where there's a really clear narrative, a really clear policy case for us to be proactive and to be thinking about wider determinants of health alongside the stuff we've always done brilliantly in healthcare. But you do need to put more focus on this, and so somehow we need to find a way of protecting investment in that, don't we?
Yeah, it'd be really interesting to see what happens. Having kind of set this new strategic kind of direction, and kind of I suppose re-articulated their values and kind of what really matters in terms of healthcare, and the fact that they're saying that we need to be bold. It'd be really interesting to see what comes from the King's Fund, and hopefully contribute.
Absolutely. Well, they look reaching out for people to partnership with. The big part of what they do is they, sort of convene, sort of meetings between leaders and sort of system influencers. But they want to bring coalface workers together as well. I mean, it'll be really interesting to see what they do. And maybe, as a community interested in person-centered care and proactive care, we should rally around them. It'd be great, wouldn't it? Perhaps for people to read that report and, share their comments and, see how that applies to where they're working and the situation they find themselves in. I think that would be a really interesting dialogue to have.
Yeah, and I suppose we do look to the King's Fund, don't we, to kind of be that kind of independent kind of body that kind of brings this thing together and can be trusted. I think that's really, really important. So when people are looking and like, well, what's the benefit of this way of working? You know that what comes from the King's Fund can be trusted because it's independent. And
Yeah.
they, I think that's really encouraging.
I agree. I think that's really important, isn't it? Because we all have vested interest. Peak Health Coaching, we have a vested interest in personalised care to some degree. I think organisations like the King Fund, like the Health Foundation, they have that sort of independence, politically independent, perhaps professionally independent as well, where they can try and cut through and say, look, actually, this is really where we should be focusing. So it's worth listening to them, I think.
Yeah. Yeah, and it is difficult, and I know, that this is something where I suppose this has been, it feels like it's been overdue. We need someone like the King's Fund to be looking at all of this, and being bold, I suppose. Um, I mean, maybe it's going to be too late for some people who are kind of finding their jobs really precarious right now, but I think down the line, the King's Fund will be a place to kind of look for, to kind of collate some of this evidence of the value of what people are doing.
Yeah, I mean, I guess it was interesting. At our conference, we had Jag Mundra, didn't we, who does work with the National Academy of Social Prescribing now to look at their data. It's done a lot of, work with the National Association of Primary Care. Again, that's another organisation that's really been leading in this space, trying to innovate. They pretty much led the primary care home, which was the precursor of the primary care network. And I know they still. There was a brilliant podcast just recently on the Pulse Live. Um, um, Oh, God, maybe I've got that wrong actually. I'll have to double check afterwards and come back and put something in. But um, where they were interviewing the head of the NAPC, and they're continuing to work really hard on how we evidence this community-based integrated approach. And there are plenty of examples around the country of places where they are really still forging ahead. But I think it would be really good, wouldn't it, to have some direct policy, some contracts for primary care that are more directly incentivizing us to do this. I think whilst ever you leave some ambiguity in there, it is tough, and like we've said before, once GPs have the option perhaps to do things that protect their bottom line versus what may be for the greater good, but have a sort of a slower win for them, it's not surprising that perhaps they're not able to make those decisions. They just can't.
Yeah. You keep mentioning the protecting the bottom line. I'm not sure it's the bottom line thing, the thing that, but the motivation thing. I think it's GPs kind of feel like they're surviving. I think that's the thing, isn't it? That they're kind of feel like they're hanging on. So again, when you feel like you're hanging on, are you looking down the line, or are you looking for someone to kind of put a hand down and pull you up? I think is that it's that's the thing that the GPs are struggling with, I think, right now. I don't know. What do you think?
Yeah, no, that's probably fair. That is probably fair. You and I have both been GP partners, and we know that tricky balance, isn't it? It's interesting. You think most about those partners meetings, isn't it? You've got an obligation to keep your business afloat. You've got responsibility for employing people, but you're also trying to hold a vision for your population that you serve and for the patients that you see day to day. But I do think it is hard for GPs to make population level decisions. I think I've seen that in primary care networks as well. It is tricky, particularly as you say, when they're trying to survive, to ask GPs to make those population level decisions by deciding who they employ. And I think maybe the next evolution for neighborhoods is perhaps to sort of share the burden, if you like, of that decision making, share out that governance a bit, so that you're not being put in a situation where you're having to decide between your business and the population. You remember, don't you, those partners meetings when you're making decisions? There's a lot of things that come into the decision making process, isn't there?
Yeah, yeah, yeah. I'm just trying to think. Now I've heard what you've kind of said about the kind of the having to make a choice, isn't it, between this or that? Actually, taking some of that choice away and say, which I know is what they did, say, well, you only spend this money on these additional roles.
Mm.
That's kind of partly what they did. But actually, and sometimes that feels not good either, because you want to be able to kind of make a decision about where you spend the resources, but they should be additional resources. It's like, here's enough that you can sustain your practice and your business and look after your population from a kind of a medical viewpoint. But here's some additional resources and some additional roles that would support you to do that. That's different, I
It
think.
is. It is. And I think, sort of sometimes you do need some frameworks. I mean, in our PCN, for instance, we negotiate right up front. When it was very early days, we said that, we need to keep some investment in the sort of social determinants of health and social prescribing. We wanted to work with a primary provider to give them some security of longevity of relationship with us. So we had a sort of 75-25 split of the budget. And when the original budget was only 120K, it didn't seem like a huge thing. It was kind of like, sort of 40K to the social prescribing, sort of 80 or that's thereabouts. My maths is probably a bit dodgy there. But then, of course, once your budget is up to over £1 million, it can seem like a lot of that budget is going into the social sector. And we did row back a bit. We rowed back to sort of 80-20, but we still kept that agreement between ourselves that 20% of our investment would be preserved for, the sort of more socially orientated, social prescribing, sort of enabling. We've wrapped some of the health coaching time into that as well. So, it's sort of sometimes you need to perhaps hold yourself accountable to some overarching rules, I think. But I think I don't know. I'm going to put my neck on the line here moving forward. I wonder if the decision makers in neighbourhoods need to be a little bit more diverse. At the moment, the final decision making on what additional roles you invest in rests with the GP practices. And maybe giving equal governance, voting power to perhaps the voluntary sector, to some of the sort of community organizations, perhaps some of the kind of mayoral teams, maybe some public health representation. It would be fairer and kinder to everybody, because then you're all bringing in your different perspectives, and you're perhaps making a more a sort of more diverse decision. But that's maybe I'm sticking my neck on the line saying that. Do you think I'm being unfair to GPs?
I don't think you're being. unfair to GPs, Ollie? Would you be unfair to GPs? I don't think it's about being unfair. I think we really understand why it is difficult to make those type of decisions where you're given some resources and you've got to kind of divvy it up. I think that's really difficult. And there's a lot that, like you said, that goes into that decision making. But if the government wants more of the people, the population to look after themselves, they're going to think, well, where are we going to put the resource that's going to help people to look after themselves? Is that into GPs and people like GPs, or is it going to be into people like social prescribers, and the care coordinators and the coaches? And I would say it's the latter.
Yeah. Yeah.
Right, but we definitely need enough resource for the GPs and the people like GPs. We definitely need enough of that, but it can't be, it feels like people are having to make a decision between one or the other, and it should be both. And
Yes.
it should be all,
It should.
including the patients themselves and the communities that they live in. It should be all of that.
Yeah.
It can't be, right, well, I can have this or that. It can't be that.
Yes. And of course, I know people watching this, some people were going, well, actually, you shouldn't be arguing over whether it's in general practice or into the more proactive social orientated care. Maybe it should come from specialist services. The bulk of investment in the NHS goes into hospital services, into those, very specialist high intervention aspects that, critical points in your life are crucial, but perhaps we've overinvested there. Other people will say, well, look, we should put more into health and less into defence and less into sort of other aspects of our budgetary division. So there's all sorts of complexities that come into it, but yes, it'll be something for us to kind of keep debating, won't it, Tim? I think maybe we've come towards the end of our time, haven't we? But I would really encourage people to have a look at those, look at the King's Fund reports, Bolder Thinking for Better Health, and look at that most recent journal in the British Journal of General Practice from Manchester University, looking at the research into social prescribing at a practice and PCN level. I think both really thought-provoking pieces. We'd love some dialogue, perhaps in the comments here on YouTube, or through LinkedIn. We'll use those two channels to kind of debate and try and support each other as we move forward on this. Any final comments from you, Tim?
No, nice one. I think I absolutely echo what you're saying. It's really important that we look at the evidence. It's really good that we stay in touch with what's happening at the King's Fund. I think they're kind of great organization, and they produce some great kind of reports which just help us kind of, I suppose, raise our own kind of expectations about what's possible, which is encouraging.
Yeah, lovely. Great chatting to you this morning. We'll try and do this every week if we can, shall we? See how we go.
See if anyone listens, Ollie.
Yeah, exactly. So do, yeah, subscribe to our channel and do put some comments if you've got some thoughts. We hope to be thought provoking. We're not the final word on this at all. Thanks, Tim.